So good morning, Dr. Fowkes.
Good morning. I gotta move my chair up. So. All right. So good morning, and another review session. So, all right. So let's show I can't remember if I showed you guys this or not, but this is an interesting case. I might have showed it to you. Did I show you this one? So this was from a small cyst. Well, actually, this one was from a very large cystic mass that was involving the leptomeninges of one of the patients. And so they went and did surgery and removed it. And so what we're seeing is a proteinaceous, okay, and then I use this. So there's a pink proteinaceous band, and then a cellular band, and then loose cellular matrix from a large cyst. And that's all that we're seeing is a multitude of this type of material. So these are fragments of tissue from cysticercosis. So it's from the tapeworm. It's a pig tapeworm. And basically, if you ingest the egg from the environment, if you have contaminated food and the egg is in the contaminated food, and you ingest the egg goes into the digestive tract, and the larva or the parasite will go through the wall of the gut into the bloodstream and then get transported to any site in the body. One of the sites that it can go to is to the brain. It can also go to skeletal muscle. So in a pig, if this larva ends up in the skeletal muscle of the pig, then the larva develops there. It will form this. It's a larva. And so this pink proteinaceous material is the inner gut lining. I think it's the gut lining of the larva. And then there's an integument around it, and it's all encapsulated in a small cyst. So if you eat the larva, in the pig the larva does not die and does not get degenerated. In the humans, it's a dead-end host. So the larva will degenerate, the body will attack it, and sometimes you'll get degenerated fragments of cyst. But in this case, it looks like it's relatively viable. Sometimes in humans, they can produce a large space, a large involvement of the leptomeninges, and that's what happened with this case. But most of the time, it's one small cyst with a little larva inside of it. And if you can recognize it radiographically, it's fairly pathognomonic for the cysticercosis. And you would not normally remove just a small, simple cyst. If it was causing seizure activities, you would end up just treating the seizures rather than removing the cyst, because the cyst will degenerate. In pigs, as I said, the larva, if it's digested, and the larva, if the meat's not cooked properly and you ingest the larva will then hook onto the side of the GI tract and will form a tapeworm. And in each of the tapeworm segments, or proglottids, there are hundreds of eggs that when the proglotid, it's basically like a big uterus. Each proglotid is like a big uterus with a whole bunch of eggs. And the tapeworm segments break off, get into the environment, break down, and release all of the eggs, and the cycle continues. So that's one interesting case that you should know so that you can recognize it anytime. All right, so let me show you a couple of vascular lesions. So this is necrotic tissue. Sorry. Oh, it's okay. So this is spinal cord, and in this, let me see. Do we have a tool? No. All right. So we have spinal. I think this is spinal. Looks like spinal cord. So we have a spinal cord, and I can't show low power to show exactly where we are, but this is focal hemosiderin, and there's blood vessels that you can see here, some of which look like they probably are occluded. A lot of hemosiderin. So sometimes you can have cavernous malformation. This is a cavernous angioma of the spinal cord. They can cause problems, and you can see them incidentally at autopsy. They obviously can cause some clinical symptoms as well in life. If they cause a lot of pressure on the spinal cord, then they can end up causing some deficits and come to attention because of the fact that it's causing deficit. And radiographically, they'll see a lesion, and if they do vascular studies, they may be able to identify that this is probably some kind of vascular malformation, especially with all the hemosiderin around it. They tend to bleed a little bit, but it's not a cavernous malformation. It's not a arteriovenous malformation that would bleed a lot. The smaller low pressure vascular malformations tend to end up like a capillary hemangioma or cavernous angiomas. They can have blood that distributes around them, small amounts of bleeding that sometimes will come to attention. I've got 3 other slides to help demonstrate this vascular lesion. So this is a Trichrome stain. And a Trichrome stain is nice because it really highlights the vessels a little bit more. You can see the blood vessel walls. And so there's quite a bit of vessels present within the spinal cord here. These vessels aren't quite so bad. This is the outer surface here. More normal spinal cord parenchyma, but then as soon as you start getting into this vascular network, you can see them. Okay. So the vessels, for the most part, look fairly back to back with not much between them, and again, it's a low blood pressure state, so they tend to, when they bleed, but not catastrophically. And then I also have an elastic stain, EVG, which also helps to highlight the cavernous malformation. So it's only there's one segment of spinal cord with central canal. It's not in that level, but it's over here. Now, if you were worried about arteriovenous malformation, then getting an EVG is helpful because it would highlight whether or not there was an internal elastic lamina present in the vessels. And this is not showing any internal elastic lamina. There's not arterialized vessels. These are instead low pressure states, venous flow, blood flow. But even venous blood flow and bleeds around these malformed vessels can cause some problems. And this is in a closed space in the spinal canal. And so any amount of bleeding in a situation like this might cause some problems for the patient and maybe some motor deficits or sensory deficits. Okay, so that's a good case. Okay, then I've also got, for comparison, this is an arterial venous malformation. One of the things that you typically see with an arterial venous malformation that you'll see right off the bat is the fact that there is usually embolization material present in the specimen. That's a first clue that you're dealing with something that's a high pressure state or arterial blood pressure. If you see embolization material in something like a meningioma or in a vascular lesion, it's an indication that the specimen has a high pressure state or a lot of vessels that they want embolized before they do surgery. So obviously in arteriovenous malformation, you have both arteries and veins, and there's a shunt between the arteries and veins, and they recruit more and more and more blood vessels into the malformation. So initially the malformation is fairly small, but then it recruits more and more blood vessels and it can get huge. The nidus of where it originates is the focus that they're trying to eliminate. Surgically or radiographically, they can end up hitting it with a radiation to try to eliminate the focus that's causing the recruitment of vessels into the malformation. It is not a true tumor, but it can grow and get bigger because of recruitment of additional vessels. So, and unfortunately, an arteriovenous malformation is a high blood pressure state. It does have arteries. It tends not to have hemosiderin around the vessels. So unlike the last specimen where we saw a lot of hemosiderin around the vessels, we're not seeing a lot of hemosiderin around these vessels. You occasionally can see some hemosiderin around them, but I'm not seeing any in this particular case. Another thing that you typically will see is that there's brain tissue. This is brain parenchyma that's intervening between the vessels. So unlike the cavernous angioma in the spinal cord that really didn't have intervening parenchyma between the different blood vessels, in an arteriovenous malformation, there typically is brain parenchyma or central nervous system parenchyma or parenchyma of any sort between the arteriovenous blood vessels. And so that's, again, another clue. Now, if we wanted, we could do a trichrome stain or an elastic stain to determine whether or not some of these vessels are arteries or veins. Obviously, the thick-walled vessels are not all arteries because the veins become arterialized. The veins obviously will not have an internal elastic lamina, only the arteries will. And in the central nervous system, just a little caveat, they have an internal elastic lamina, but they do not have an external elastic lamina. That's the one difference between arteries in the central nervous system. As soon as you enter the skull, the internal carotid arteries, as soon as they enter the skull, no longer have an external elastic lamina, and it's just one difference in the vascular supply to the brain. They're slightly different than the systemic blood supply, and I don't know why. But I don't have any other stains on this one, but it was just a demonstration of other vascular lesions.
What would be the differential in a slide between every malformation? So what other differences? What are the things?
So it would be, is it a cavernoma? Is it a capillary hemangioma? Is it a arteriovenous malformation? Cavernomas, not uncommonly, will be near the front of the brain. They're large ectatic vessels so the vessels are dilated. They're usually back to back. So cavernoma is well recognized by the surgeons as being a vascular malformation. They're typically more of a low blood pressure state. But they can cause symptoms. Again, you can end up having expansion of these vessels in a region that doesn't have a lot of room for there's just not a lot of room. So having something expanding just because of dilatation of the vessels or abnormal dilatation can cause problems. If there's any amount of bleeding around the vessels with hemosiderin deposition, it's very irritating. And so that can cause some clinical symptoms as well. So they tend to want to remove it so that it doesn't cause problems. But typically going in, they have a clue that they may be dealing with a cavernoma. A capillary hemangioma, they also typically will have hemosiderin around them. They tend to be multifocal in multiple regions throughout the central nervous system. And so radiographically, the neuroradiologists are very familiar with them. If they see one, they have a signature because of the hemosiderin. And so usually when they're looking at a capillary hemangioma, they see multiple ones. So they'll look for it, and they don't bother going after them. They're well recognized. That at autopsy you can see them because they're a little brown spot that you see when you cut the tissue. All of a sudden you see this little brown spot in the tissue. If you take section, it's going to be a capillary hemangioma. So those are the main vascular.
Aneurysm is not, right?
An arteriovenous malformation, typically there's not hemosiderin around it. When they bleed, they usually bleed catastrophically and kill the patient. If the patient's lucky enough to survive a bleed, then they clinically will try to treat the arteriovenous malformation so that it doesn't rebleed, because if it does rebleed, again, it can be a catastrophic rebleed because it's high blood pressure. So when it bleeds a lot, and there's just not a lot of room in the brain for blood. So that can cause problems. Okay. This is a cystic lesion in the cerebellum of a child. So now we're going off. We're no longer talking about vascular malformations. We're talking about tumors. Now, let me drive this around just a little bit. So the most important thing in neuropathology is recognizing what's normal, what's not, what's abnormal. So there is a moderately cellular tissue here. If I drive around just a little bit, and there's some areas that are kind of loosely arranged, and other areas where it's maybe a little bit more cellular. And then there's also tissue over here that doesn't maybe at first glance look all that normal, but this tissue is actually cerebellum that is atrophic. It has lost, this is the cerebellar cortex, and so this is some of the granular neurons of the cerebellar cortex. A lot of the Purkinje cells are gone. There may be some left, but not all of them. And so there's dropout of Purkinje cells, dropout of granular neurons, and this is just atrophic cerebellar cortex. So you got to know that that's what you're dealing with. And on frozen section, when you get a frozen section specimen, if you do a smear from the cerebellum, if you have small granular neurons in the smear, they can look lymphoid. So always be cognizant of what you're smearing, what kind of tissue you're smearing when you're looking at a frozen section specimen, because you don't want to confuse normal granular neurons from the cerebellum as lymphoma. I have seen it done. So, but there is this population of atypical cells as well. So again, this is a cystic lesion in a child in the cerebellum. And let's see, if we go back over to this normal tissue, not sure if I can find any. So typically you can have next to areas of, so this tumor expands as an expansile mass that pushes on the normal adjacent brain tissue and causes an irritation. And when it causes an irritation, it causes the development of Rosenthal fibers. And Rosenthal fibers are here. So Rosenthal fibers are intracytoplasmic eosinophilic blobs. Oops, that's about as high as we go, sorry. They can be variably shaped. And so these, let's see if I can move this. So these little pink blobs that are variably shaped are all Rosenthal fibers. And it's not pathognomonic for this lesion. It can occur with any kind of brain irritation, and it can develop fairly quickly. But when you see them, it's kind of reassuring to help you say, yes, this is the type of tumor it is. This tumor has some cells that look almost oligodendroglial-like, with round nuclei and paranuclear halos, which can be present. But again, it's only moderately cellular, and there's loose and cellular areas. And if we go to some other regions, hopefully we'll see there's going to be cells that are, let's see if I can see it. So there's one, right? That's one in the middle. Let's see. Yeah, so this is a pilocytic astrocytoma. I'm looking for pilar cells, so pilar or hair-like, and there's some cells that are bipolar, where the nucleus is thin and the cytoplasm is present. There's a nice one. No, your field is not the same as what I'm seeing. Okay, let's see, where is this? So so you have, let's still try to find some. Yeah, my field is definitely different than yours. Let's see. Okay, so that looks more like a vessel. I mean, so it's, I don't know if that's a vessel or if that's one of the tumor cells, but you're looking for, oops. Let's go this way. So cells like this, where it's a thin nucleus and there's cytoplasm in two directions, streaming off of both ends of the thin nucleus. Those are pilar cells. They're hair-like cells. There's another one down here. So you've got pilar cells. You've got cells that look kind of like oligodendroglial cells. No mitoses. If you do a MIB1 or proliferation index, Q67, the labeling index is usually very, very low, 2%. Maybe, and you can have vascular proliferation. You can have some thick vessels. It does not increase the grade. However, if you see more than an occasional mitotic figure, it raises the possibility of it transforming to a more atypical or anaplastic phenotype. Oops. Oops, I don't know what happened.
Oh, yeah.
Okay, so that's a pilocytic astrocytoma. With a pilocytic astrocytoma, sometimes you also have eosinophilic granular bodies. eosinophilic granule bodies, unlike Rosenthal fibers, if you see eosinophilic, I don't know that I could find any on here, but eosinophilic granular bodies, let's see if I can find one. They are, if you see them, they're typically not in the tumor itself, but in the surrounding parenchyma. They might be in the tumor, but if so, you see them in the adjacent tissue. It's if you eosinophilic granule bodies are basically round granular collections in the tissue that if you see them in a low-grade tumor in a kid, it's an indication that you're dealing with a low-grade tumor. They're a reassuring sign that the tumor is low-grade. If you see one with a tumor, if you see eosinophilic granular bodies in a tumor, then you got to be careful and back off, because if you think it's a higher grade tumor, it might not be. So it might not, if you think it's an infiltrating astrocytoma and you see eosinophilic granular bodies, it's an indication that you might not be dealing with an infiltrating low-grade astrocytoma, but instead you might be dealing with some other kind of benign low-grade tumor in a child. So you just have to be cautious. I can't see one right offhand, but okay.
It's not specific for biological.
No, it's not pathognomonic for anything, but it is an indication of a low-grade process. Okay. Let's go back to the infectious theme. I don't think I showed you this last time. So we have, this is again, you got to know what you're looking at. So this is not cerebellum. This is a fetal brain. And so we're seeing fragmentation of the brain. So there's multiple fragments. And this cellular ribbon that we're seeing, where's my arrow? So this cellular ribbon is the cortex, the cerebral cortex. And let's see, it is fragmented. I'm going to try and go to more of the central region. Okay. So sometimes the fetuses become infected because the mother is infected, and the infection can be identified in infected cells. So yeah. So these cells are infected, and so what you're seeing are cells that have virus in the cytoplasm of the cell as well as in the nuclei. Let me show you a couple more. So this is, so I mean, if you look at this cell, the nucleus has this pink material in the center of the nucleus and deforming the nucleus. And then the cell cytoplasm is also just chock full of virus. There's some more. So they're all over the place. This is CMV. And so the fetus died because of the CMV infection. A lot of the times, if you have a CMV infection, you get ventriculitis, you get infection of cells along the ventricle of the brain. But in heavy infections, say in patients that have both CMV as well as HIV, you can actually see it in other locations aside from the ventricle region. You can see it in the cortex, in neurons within the cortex and other locations. So, you know, if you suspect that there's a viral infection, you know, you have to look, but when it's a heavy infection, you can see it in a lot of places and see a lot of cells infected. In patients that have HIV and CMV, the combination of the two viruses together make both infections worse. And so you typically have very heavy infections, and you can see the CMV pretty easily. When you see it, it's pretty pathognomonic for a viral infection. It's not necessarily just CMV, but it's a viral infection. CMV is the most common virus that will cause this kind of change. Okay. Well,
were there calcifications present in this baby?
I think there were. I actually think there were. That is
and those calcifications are usually paraventricular as well,
yes,
right?
Yes, that's correct.
Whereas toxo is more diffuse calcification.
Right. So toxo, you can end up. I do have a toxo here, but I'm not sure if I can find it. Toxo is you can have. They look like abscesses, and it can be multifocal, and the tachyzoids, and I think it's the tachyzoids that it's encapsulated, and then when they break open, it's the bradyzoids. The toxo organisms, you can see them if you've got just the contained bradyzoid, which is enclosing all of the organisms, the multiple organisms before they break open. Those are visible, but once it's broken open and the individual organisms are released, it's much harder to identify them. Let me see if I can maybe find my toxo. I'm pretty sure I've got one. Let's see. I think I looked for it last time and I couldn't quite find it. Ah, here it is. Okay, I got it. All right, so let's look at toxo. They do have. So this patient had an abscess, and they weren't sure if it was a bacterial abscess or toxo, because again, toxo is typically going to be in a situation where the patient has immunosuppression. It formed an abscess-like cavity, and so we're seeing the center portion of the abscess cavity. And in this case, the cavity there's chronic inflammatory cells. There's mostly macrophages. But then I do have it dotted so that I can find the stupid thing, because it can be very tedious trying to find the organisms. So let me actually go to my dots. There's my dot. So it's great to be able to show you what it's supposed to look like, because seeing it in the textbook is one thing, but seeing it live under the microscope is helpful. So right dead center is the organism. They tend to be, in fact, there's two of them. So this is one here, and this is one here. And they tend to be present in macrophages. And if you focus up and down, you can see the individual organisms. So these are encapsulated, and they will break open and release the individual organisms, which would be much harder to see. They're tiny. You can see just these little black dots. It's going to be the released organisms. So these here might actually be released tachyzoids. So you can see that they can be tricky. You can identify them, though, under an H&E. So before you even get an immunostain, if you look hard and look long, you can find them. But it is a little bit tricky. Look at the relationship of the blood vessels and the oligodendrocytes or astrocytes that are present here. So the cells adjacent to them, this is might be an oligodendrocyte, or this. You have these cells that are adjacent that are clearly smaller. Here's a blood vessel and a red blood cell. So the red blood cells are considerably smaller than the encapsulated organism. So keep that in mind. This is what you're looking for. This is the size. They're not invisible, but you do have to look hard. The easiest place to find them is adjacent to the cavity. So this is the tissue. Here's the abscess cavity. And so this tissue, sorry, my microscope is all funky. Oh. So they're present right at the periphery. That's one of the easiest ways to find them. Okay, so they're at the edge. To me, that's been the easiest place to find them. If you find one, it's pathognomonic, it's diagnostic. So if you've got one, it's great. And you can stop. The immunostain is okay. You have to have a good control in order to use the immunostain, because you can have, like any immunostain, overstaining or understaining of this. You have to have a good stain and a good positive control to be sure that the stain is working properly. A lot of the times when you use a stain for a case of actual toxoplasmosis, you get a lot of staining because there truly are a lot of organisms that are present. But in order to be definitive on only an immunostain without seeing the encapsulated organism, you have to know that your antibody works properly and not overcall cases that may be overstaining. Okay? All right, what's next? Let's see. All right, so then there's this. Okay, so now we have, oh, I think I showed you this. I showed you this. Okay. Oh, no, I'm going to show you this. So this is an autopsy case, and it's been stained with Luxol Fast Blue. So it's actually a combination of Luxol Fast Blue and H&E. Luxol Fast Blue stains myelin fibers in nerves or axons. And so the blue is are the axons within the brain parenchyma that are coursing through white matter tracts. And then you can see that there's gray matter neurons here as well. The Luxol Fast Blue will help with cases where you have preservation of axons, but demyelination, so loss of the myelin. So if you do a Luxol Fast Blue stain and you do an axonal stain, so neurofilament on immunostain, or a Bilshowski stain, which is a silver stain, which will stain axons or some other axonal marker, you want to see a relative preservation of the axons with loss of myelin in order to say that something is demyelinating. But it's a nice stain to look at the overall preservation of axons in the brain. So we use it all the time for autopsy cases, because if there's an infarct will have loss of axons and loss of myelin both, because it's causing necrosis of the tissue. So that's the difference as far as a demyelinating process. So what I'm going to look for, I don't know if this slide has it. I've got two slides from this case. We've got the ventricular lining. I'm looking for pigmented cells, and I'm not sure. Here's some. So there's pigmented neurons in this is subthalamic region of the brain. So we were just in thalamus. I showed you white matter tracts and a bunch of deep gray matter neurons, not cortex. And subjacent to the thalamus is the substantia nigra. So sometimes you can have substantia nigra where if you cut an axial plane, axial section through the midbrain, you're going to see the substantia nigra the way that you see it in the textbook. But if you do a coronal section and get the subthalamic nuclei, sometimes you get a portion of the substantia nigra. So that's what we've got here. And I just want to look at these pigmented neurons. So I'm looking for Lewy bodies. No. I don't know that that's a Lewy body. It might be just a corpora amylacia. Corpora amylacia can look like Lewy bodies. You want to see them in a pigmented cell. And that's probably not one either. So in the substantia nigra and locus ceruleus is in the upper pons. It also has pigmented neurons. And the locus ceruleus, like the substantia nigra, has pigmented neurons. And if there are Lewy bodies, you'll see them both places typically. Now, you don't have to always see them. You might have just a small number of Lewy bodies. You might only see one cell that has a Lewy body, in which case, I think that might be one. It's hard to be sure that that's a pigmented neuron, but I think that is one. Yeah, right there. So normally the pigmented neurons, when it's a true Lewy body, the other one might have been, but wasn't quite sure. This one I think is. So a Lewy body in the substantia nigra and locus ceruleus has a pink blob surrounded by a fibrillary radiating halo around the pink blob. The pink blob does not have to be round. It can be irregular. But that looks like it's one. Now, I want to show you next a section of cerebral cortex from this patient. Now, this patient did not have symptoms of Parkinson's disease. Instead, this patient had symptoms of psychiatric abnormalities. He was older, I think he was in his 70s or 80s, and he had visual hallucinations. Was a physician, very smart guy, but was having psychiatric presented with psychiatric dementing symptoms and visual hallucinations, and was not Parkinsonian, but his brainstem, the substantia nigra and the locus ceruleus had a lot of Lewy bodies.
This is Lewy body dementia?
Yes. So Lewy body dementia, it's diffuse Lewy body disease, and the cortical Lewy bodies do not look like the Lewy bodies of the midbrain and pons. So instead, they look like a proteinaceous blob in the neuron, but they're really difficult to appreciate. They're small, and this is a situation where having a stain for alpha-synuclein is very helpful, because they're just, here it is. They're so difficult to see. They do not form that radiating halo around the proteinaceous glob. So this right in the center, this is a cortical Lewy body. So you can see that it's very different from what we see in the substantia nigra. In the substantia nigra, you can have these really dark pink or light pink. The one that we just saw was a little bit light pink. They can be really dark pink, but they always have that radiating halo around them. Again, they can be club-shaped, really irregular. Most of them are round. You can have multiple in one cell, but they're in the substantia nigra and locus ceruleus. They always have that radiating halo around them. In the cortical Lewy bodies, they don't. So there's this blob that has depth to it under the microscope, and yet the nucleus, the neuron looks abnormal. The nucleus is pushed off to the side, and there's no radiating halo. You stain the tissues for alpha-synuclein, and you will find a lot more. The ones that you can see, I only found one. This person, this patient had diffuse Lewy body disease and was demented. And I think if we had had an antibody available, we probably would have found a lot of them. But this was the only one that I was able to find microscopically. So it's a really interesting case. Okay, so there's that. What else do we got here? Now I want to show you one case. So we have a case here. It's actually multiple cases, but I've compiled them into clinical associated diseases. So this is a portion of brain. I think I showed you this one. So there's a portion of brain, let's try to, I don't know if I can orient very well. It's not quite normal brain. I'm trying to look for normal cortex, but I'm not finding good normal cortex. But that's for a reason. That's because this patient had the portion of brain that was removed because it was abnormal. So if we look here, I don't know if you can appreciate it, but there are great big neurons here in the middle of the tissue. They are clearly neurons because they have Nissl substance. So the Nissl substance is this blue-gray like material in the cytoplasm of the neuron. So let's see if I can point that out. So there's the nucleus, and then there's this blue-gray like material in the cytoplasm. So here's the nucleus, and around the nucleus and within the cytoplasm is this blue-gray like material. That's Nissl substance. If the cell dies, then the Nissl substance will go away. So that's another indication. If you have acute hypoxic ischemic change, the cytoplasm becomes hypereosinophilic. You have loss of the Nissl substance. The nucleus becomes either very pycnotic and blue, or it becomes very pale and pink, and you have loss of the nuclear membrane. That's an indication of acute hypoxic ischemic change, which you can see typically within about 6 hours after an injury, an ischemic injury. Now, next to this cell, there's another cell here. This is probably an astrocyte with abundant eosinophilic cytoplasm. This is probably a balloon. It's called a balloon neuron, or a balloon cell. So balloon cells and large ganglion-like cells in the cortex in an abnormal distribution, commonly in the subjacent white matter or in the cortex itself. This is a cortical dysplasia or a cortical tuber associated with tuberous sclerosis. So when you get tuberous sclerosis, there are other things that you have to be worried about. So I've been able to pull a few things. This is from the right colon, and it is a lymphangiomatosis. So with tuberous sclerosis, you can get lymphangiomatosis. So if you have lymphangiomatosis, one of the things that you want to be concerned about is tuberous sclerosis and looking in the brain to see whether or not, so there's these large dilated lymphatic channels. And usually the clinician tells you, you get this clinical symptom or clinical story. And then you find it, and yes, you've got these large dilated lymphatic channels, which now we have markers for lymphatic channels. So you can use a lymphatic specific marker to confirm that this is lymphatic. If you find this as a diagnostic entity, you have to scan the brain, make sure that the patient doesn't have tumors in the brain. What other things do you have to worry about in a patient that has tuberous sclerosis? So if they have tumors in the brain, they can have seizures. So knowing that they have a tumor in the brain is important, but they also get tumors, other tumors. So this is a tumor. I think I showed you this last time. This is a tumor in the subventricular region of the brain. No mitotic figures, but very large, giant-like cells, right? They almost look ganglion-like. And it's just a sea of these giant cells. And it's amazing. We got this on frozen section, and they look ganglion-like, but I don't think they've got Nissl substance. So they're huge. On a smear, if you have cells like this, one of the differentials might be a germinoma in the brain, because germinomas typically in the brain will have huge cells with a lot of cytoplasm, a very large prominent nuclei with a prominent nucleolus, and a lot of lymphocytes in the background. So that helps you differentiate germinoma. Would it be in the subventricular region? Probably not, although we just recently had a case of a germinoma that was present in the basal ganglia. So typically a germinoma is either in the pineal region, in the near the infundibulum or pituitary, or near the optic chiasm. Those are, or the hypothalamus. Those are the primary regions where you end up seeing a germinoma, typically in a young kid.
This one is SEGA? This
is a SEGA. So again, this is a benign tumor. Well, it's not necessarily all that benign. I mean, even benign things can kill people. I can't remember what WHO grade the SEGAs are. They're not proliferative. Maybe somebody could look up real quick what the WHO grade for the SEGA is. But they occur in a setting of tuberous sclerosis. They are a tumor and they will grow. If you excise the entire tumor, they usually do very well though. So that's a SEGA, also part of tuberous sclerosis. And okay, and then this is a renal mass. This is a kidney. And this is a angiomyolipoma. What is it?
This is grade 1.
Grade 1. It is grade 1. Okay. I don't want to say the wrong thing. So another one of the things that you have to worry about, if you have a tumor in the brain, then you have to look in the kidney to see if there's any abnormalities in the kidney. So this is one of the lesions that you can get in the kidney with tuberous sclerosis. And this is the angiomyolipoma. So I'm not a soft tissue person. I don't know that I would be able to recognize this as I'm sure there's immunostains that go with this. So if you have a diagnosis of so if you get a tuber if you have a cortical dysplasia, cortical dysplasia can look just like a tumor. So if you have cortical dysplasia, it's a good idea to alert the clinician that maybe they should do genetic testing for tuberous sclerosis, just to be sure. And because if they do have a genetic abnormality, if they truly do have the mutation, they're at risk for these other systemic tumors. And so you have to be alert to them and look for them. For the boards, I'm not, I don't write boards, but for the boards, if you have a case of tuberous sclerosis or neurofibroma, make sure you know all of the different crazy things that can be associated with this, with these genetic abnormalities, because you need to recognize them. In the brain, they have presentations. Neurofibromatosis type 1, type 2 present in the central nervous system. Tuberous sclerosis presents in the central nervous system. Von HippelLindau presents in the central nervous system. But they also have systemic presentations as well. And so we know them because we see the central nervous system components. But you need to know them too, because if you have a systemic presentation, you need to look elsewhere in the central nervous system for presentations as well. Okay, so that's my pitch on that. Okay, what else? Oh, let me do, so speaking of which, so this is von HippelLindau syndrome and hemangioparasite or hemangioblastoma. So hemangioblastomas typically they can be multifocal. They can be anywhere in the central nervous system. So what you can see immediately, even at this magnification, is that this tumor is really vascular. So if you're lucky and you get this tumor resected, you get a portion of the tumor that is congested so that you can recognize that this tumor is associated with a rich network of capillaries. The capillaries, the vessels, are not considered to be part of the tumor. The tumor cells are actually the light pink cells that are adjacent to these blood vessels. So these are the tumor cells. So the stromal cells are the tumor cells. They can be pleomorphic. They can look really atypical, but there's usually no mitotic figures. Part of the problem with this tumor is if the surgeon happens to just biopsy it, or if you just get a little bit of this tumor and not much else, some of the cells can stain with GFAP, and some of the cells can have atypical nuclei. So you don't want to mistake this for a glioma. It's not. It's usually a solid and cystic tumor that abuts a normal brain parenchyma with a pushing border. And in the pushing border, we have Rosenthal fibers. So this is a Rosenthal fiber, this is a Rosenthal fiber, this is a Rosenthal fiber. There's a whole bunch of them. So this is a pushing border, irritating the brain. It's a well-circumscribed mass. They don't always have cysts associated with them, but they can. They can be multifocal. They're not uncommonly multifocal. They can present anywhere in the central nervous system. They can present in the eye. They can present in the spinal cord. So, but once you see one and you recognize it under low power, you can have degenerative cystic changes. So this has the main tumor mass Usually it's a cyst with a mural nodule, and the mural nodule is the tumor. So this is a cystic mass, and the tumor is abutting the cyst. But you can see sometimes the vessels within this mass, sorry, driving everybody nuts. Sometimes the cystic spaces, you have hyalinized blood vessels with this mass too. Hyalinized vessels and cystic spaces, not uncommonly. Sometimes the surgeon, and you can get a little bit of hemosiderin, that's not uncommon. And I believe the tumor produces erythropoietin. So just recognize this. And again, this is von Hippel-Lindau syndrome. So it's going to be associated with other systemic diseases as well. Okay. And I think it's also has the risk for, it's the chromosome 3 and the renal cell carcinoma is associated. It can be associated. I think of tuberous sclerosis as forming more solid masses. There's subungual fibromas. Von Hippel-Lindau, for me, it helps me remember von Hippel-Lindau with cystic things, so cysts in the pancreas, things like that. Renal cell carcinoma, chromosome 3, but cystic lesions. Okay. All right. What else we got? Oh, we're almost out of time. Want one more?
Yep.
Okay. All right. So let me do. So this is not quite neuropathology, but you get it in neuropathology. So we got bone. This was in the area of the clivus, or the spine. It's usually at the skull base or at the in the spinal cord.
It's like a chordoma.
It is a chordoma. And we not uncommonly end up getting chordomas because they're at the skull base. You get them at the clivus. So if you have a tumor that is midline and causing bony destruction, think of a chordoma. The cells stain with cytokeratin. They do not stain with D240, which would stain chondrosarcoma. They are worse than a chondrosarcoma because they recur. They're more indolent than that low-grade chondrosarcoma, I should say low-grade. Chondrosarcomas typically will cause bony erosion that is not midline, but more off midline. And obviously, chondrosarcomas are not going to be cytokeratin positive. These will stain with almost any cytokeratins. CAM, AE1, AE3, you can stain them with EMA, I think, also stains the cells. Even if you get a gross total resection where all your margins are clean in the spinal cord, sacrum is a very common site for the chordomas to occur in the spinal canal or spinal cord. They'll grow out from the spine and they can impinge on the pelvic organs in the sacrum. And you can get an unblocked resection with clean margins, and I've seen it still recur despite having clean margins. They are malignant, they're aggressive, they tend to end up having problems. So you'll see them time and time again. The clival ones, you get resections. A few years later, you get another resection and another resection. So, they're very indolent. Let me show you one more. They don't always, sometimes they look a little different one to another. If you get an unblocked resection, it's really nice because you end up having the cells are lobulated, and you have the phycoliferous cells, the bubbly cytoplasm, and cords of cells. You can have a chondroid chordoma, and a chondroid chordoma looks like it's cartilage, but there's adjacent areas that are more typical chordoid, and they all stain with cytokeratin markers. So even though it has some kind of chondroid differentiation. Sometimes it's still a chordoma, but it's a chondroid chordoma. So this is just another chordoma. So sometimes the cells have bubbly cytoplasm, sometimes they look a little myxoid, but the cells typically are streaming. Another tumor that can be confused for a chordoma is a chordoid meningioma, and a chordoid meningioma has streaming chordoid-like cells. It can have a myxoid background, but there's almost always areas of the meningioma that look like normal meningioma with whorl formations. And the big difference is that they're going to stain with, the nuclei can typically stain with PR, the cells stain with EMA, but a chordoma, I think they also can stain with EMA. They're going to be in a different location. In meningioma, typically it's going to be a mass lesion in the dura, with a dural tail, associated dural tail, and the clinicians usually know where they're working. This has bony destruction, whereas meningioma is going to end up having bony formation. They like producing bone. They grow into the skull. Doesn't mean it's invasive. Doesn't mean it changes its grade. Meningiomas like dura. They like skull. They grow into the skull. They cause bony spicule formation, new bone formation, as well as infiltrating into that bone and causing expansion of the bony plate and thickening of the skull because of new bone formation. Chordomas cause bony destruction. Okay?
So in the lower sacral region, it can be confused with myxopapillary ependymoma.
The myxopapillary ependymomas are arising from the central canal of the spinal cord itself. A chordoma arises from the spine, and so it's usually a tumor growth, usually on the anterior surface of the spine, expanding out. It is not within the central canal. It's outside of the central. It's outside of. It's extraaxial. It's not within the central nervous system. It's not intradural. It's not intraparenchymal within the central nervous system. So it's outside of the central nervous system, which is why usually they can recognize it as being not related to neuropathology. Unfortunately, when you're a neuropathologist, you still get these because it's the neurosurgeon that's getting them. The neurosurgeons that sometimes are going to be the ones taking sacral specimens, and it's going to be the neurosurgeons typically that are going to take the clival region tumors as well. So as a neuropathologist, you see soft tissue tumors, you see bone tumors, you see head and neck tumors. And so, you know, not every neuropathologist ends up wanting to get an expertise in some of these other subspecialty areas, but it's a good idea to have some exposure and some knowledge of these regions because your neurosurgeons are going to be communicating with you. If you have somebody else around, a bone or soft tissue specialist or head and neck pathologist to help with some of the cases that are less commonly seen in neuropathology, that's fine. But this is a type of tumor that is typically seen in neuropathology. And so either a neuropathologist or a bone and soft tissue pathologist can certainly sign them out. And there's communication. There are colleagues. And so, we work together. Sometimes they show us tumors that are not expected in bone and soft tissue that are more central nervous system related. And sometimes we show them tumors. Okay. Any other questions? All right. Well, thank you.
Thank you.
Sure.
Sorry.